today I'll be speaking on the mallet fractures and the phalangeal fracture. So both are huge topics, but I'll try to make it as concise and simple as possible. So mallet finger, this classification most of you are aware of, but we'll be focusing more on the soft tissue and a bony mallet. So what is soft tissue mallet? Just a mallet deformity without the fracture. So that means, the zone tendon avulsion is there without any involving the bone. So you see that there's a flexion deformity at the DIP joint and the compensatory swan neck at the PIP joint. So what do you do with these cases? So if the patient is good compliance means, we advise a mallet splint. So one thing you should remember, the splint, it has to be worn for at least 6 weeks, 24/7. It's not like it's intermittent splinting. So if the patient is willing for that, then you give a splint. And you have to mobilize the PIP joint so that you can avoid stiffness. So if the patient is high demand, for example, a surgeon or a sports person, he wants to get back to work, you can't keep them on a splint for 6 weeks. So in those cases, we do joint transfixation. So you're simple, but just passing a wire to the DIP joint. So you mark the bone using a K-wire and a marker under the C-arm guidance, and you just pass a 1 or 1.2 mm K-wire from the tip to the proximal phalanx. So you have to cut the tip of the wire just under the pulp so that it's buried, and it's also enough that you can remove it after 6 weeks. So AO recommends it pass it to the subchondral bone. You have to be very careful because if you go a little beyond, you may go into the PIP joint, which can be more problem. If you're too short, the wire can bury inside. Then removing will be a bigger challenge than the initial fracture. So this was, so what I do is I just put it oblique. So even if it buries, it can come outside from the other end. So this is a case after 4 weeks where you can see the mallet is corrected. So coming to the bony mallet. Bony mallet, you see there are many variants. So this you can see the first one is a small fragment. The second one is more than 50%, it's unstable. The third one is very notorious. You see there is a volar subluxation, dislocation. These are the very tough mallet things to address. So bony mallet again, reducible. What is reducible? You can put a mallet splint and look in the X-ray. If it's reducible, then same thing. Just to do the splint or DIP joint wire which I just showed. If it's not reducible, then you should take up for further intervention, which could involve the pinning which I'm going to describe, or even open reduction sometimes. So see what happens is when you extend it, the fracture is trying to go away from the joint. So these are the ones which require some intervention. So this is a high demand patient, of course, with a fracture which is not completely reduced on extension. So we did this extension block pinning. I'll come to that in the next few slides. So here, this is another case with 4 weeks of neglected. See what happens, the bone is subluxing volarly. There's a gap seen at the mallet in the fracture. So in this, what we do is, we have to do some manipulation. Just extension will not help. We need to translate. So we know that mallet reduce on extension. Sometimes you also have to flex the distal phalanx to get the reduction. So here what you do is you pass a wire to the extensor tendon so that it stays in place. That's a baby fragment. Then you move the mother fragment of the big fragment to the smaller fragment. Unlike other fractures where you take the smaller bone to the bigger bone, here you get the bigger bone to the smaller bone. Then you transfix with the DIP, the K-wire. See that K-wire is very critical because if you go inside the fracture will not heal. So this is extensor block pinning. So you see this paper from Stern. So here it describes the series. The 45% of the patients non-operative have complications, but they are temporary. But 53% of surgical have complications. So this is not mallet is not some fracture where surgery can be done rampantly. So just summarizing the mallet, as long as possible, try to go conservative unless the DIP joint is not reducible. And remember, surgical complications is high. I think in today's talk, if somebody is saying don't operate on these fractures, this mallet finger, I think we should try to avoid as much as possible to operate. So to choose the right fracture and the patient if you're planning for surgery. So coming to the second part of my talk, it's a phalangeal fracture. I think any fracture phalanges, you have to start with this statement. So hand fractures can be complicated by deformity from no treatment, stiffness from over treatment, and both deformity and stiffness from poor treatment. So you see this is a fracture, I think you see this very commonly. So you see this fracture of the P1 fracture with a lean straight K-wire. So it's all healed well. It looks very good healing, but you see there's no movement. Why there's no movement? Because it's been immobilized and all the tendons are stuck. So radiological union does not mean a functional outcome in, especially in hand. So then how much, what are the indications to fix a phalangeal fracture? See, this is a rotational deformity, what you see. You see the middle finger, it's trying to go away. This is rotational deformity, and this is the angular deformity. So rotation is acceptable to 0 degrees, angulation up to 10 degrees. Each shortening may not cause much functional disability, but they'll have some lag in the PIP joint. So what are the indications again? So any open fracture, you need to fix it. Suppose a multiple phalangeal fractures, a combined fracture. Suppose if you're having fixing a distal radius, though the phalanx is undisplaced, it's good to put a pin there so that you can start mobilizing early. And interarticular fractures, of course, you need. So in my practice, 99% I use K-wires. I never use plates. Screws, of course, as Dr. Sudhir said, in interarticular fractures. But if it's a non-articular, just K-wires will do the job. So I'll just show you a few cases. So for any of the fixation, I think of course most of us have Manman drill, but this is a very bad drill for phalangeal fractures. You're going to struggle a lot, and you need a good tip cutter, the K-wire cutter, and K-wire is 1.2. If you're using a single wire, 1.5 mm. So preferably 1 and 1.2 mm. So here you can see the displaced radially angulated fracture, which we did a close reduction and fixed it. So you see this K-wires should never breach the joint, whatever joint. Suppose if you're doing a P2 fracture, never breach the PIP joint. If you're doing a P1, never breach the MCP joint, and it should always be a crisscross for a better stability. So coming to our index case, here you can see this fracture is what P1 fracture. You see the proximal part is flexed. That's because of the intrinsics, and the distal part is extended because of the extensor tendon. And this patient, you can see this hand is diverging. So there is some rotational and angulation deformity. So how do you start it? You use this folded sheet. Why? Because to get the MCP flex, so the intrinsics relax. So sit on the corner of one side, surgeon should sit on the one side, and in the middle towards the arm table, the assistant can help you manipulate, and the C-arm from the other side. So first you pass it from the base. See again here, make sure you never breach the joint. So once you are in the base, then you can ask the assistant or you yourself can manipulate the distal end to get it reduced, and then you pass the wire. So be careful of this excess wire, because what happens once the swelling comes down, that is going to impinge the skin and patient will complain of pain. So, same crisscross wire. Similarly, we did this for the proximal, the ring finger. So K-wire cutting, other one is important thing is after we bend and cut, we have a habit of turning the K-wire so that we does not poke the dressing. But by turning the wire, you're going to loosen the purchase. So because these are all smooth pins and not the threaded ones. So please confirm the rotation. I think that is the most intolerable thing in a phalangeal fracture. Once you're happy with that, then you can leave it. And also check the MCP joint. When you passively move it, it should be free. That means you're not in the collateral or the tendon. So of course, we can mobilize it early if you are happy with the fixation, and this is after 3 months. So phalangeal fracture, just to summarize, first important thing is you miss a lot of injuries by not getting a proper X-ray. Always get the lateral X-ray of the finger, okay? And avoid breaching the joint, as I said, and try to choose a fixation where you can mobilize early. Thank you so much.